demande à Dr. Ingelmo de nous joindre. Il est responsable côté pédiatrique McGill pour la douleur. Et je suis très content qu'il va partager ses pensées avec nous aujourd'hui. Merci beaucoup.
So, merci Joe. Merci Dr. El-Hamansi on the name of the organizing committee. Mon français est horrible. Je pense que c'est une insulte à la langue française. Je continue à parler en français. Je suis plus confortable à parler en anglais. Je peux prendre la question en français aussi. Merci pour votre compréhension. So, I'm a newcomer in Quebec. I arrived a few years ago. And if every newcomer, you're always looking at yourself as, I'm in the right place. Can you tell me, hands, raise your hands, which of you has had pain in the last 3 months or have recurrent pain in the last year? Okay, thinks that I'm in the right place. Okay, you really would think calling me. Thank you. Thank you for calling me because I don't have just bad news for you. So the idea of this is I'm not here to teach, I'm here to learn. Basically, you are going to tell me what are happening in your life because I'm a pain specialist. I have that nice title. But I'm trying to understand this pain issue in the last 30 years, and I'm still putting a lot of questions. So probably the best way to understand pain is you explain me what is your pain. I'm part of this, and I'm very thankful for all these sponsors that are trying to help me on doing our research. So as you said, at least half of the people here has pain. It could be up to 90%. Your pains may come from arthrosis, arthritis, bone overgrowth. How many of you have headaches? Ooh, that's the right place again. So, and probably you are in the good target of people who are having headache more than others around the heritage problems. And how many of you have pain every day? Which is something that happened to me too. But the main problem is that these pains are not diagnosed, and most of the time are not treated. And the older we became, the more pain we will have. So my father said, if you are 50 and you wake up without any pain, it's because you are dead. If you put all together with some particular conditions, you may understand that your pain will change. And this change is where it's starting, how it's spreading, how it's going, that pain. More likely, it's not in super intense pain, but it's always there, it's a noise, right? And it's aching, it's sharpening, it's changing, it's not the same, it's random, it's not all the place. And sometimes I start to feel that it's not the same pain, but it's going around me. It's spreading. Is that correct? Is something that happened? You say yes. Or you like me, or you say yes because you have it. Okay. So basically, these pains most of the time interfere with life, which is the most important part of this thing, our life. What we are able to do and how we can enjoy our life and do our job and take care of my kids and think about the future. So pain and disability are really interconnected. The more you have pain, the more you expect to have more disabled. Probably not. But pain intensity is related to people that are growing, don't call them us older, have bad health, and they have a lot of physical related disability. And on the other side, related disability is more frequent in girls or females, in all the individuals, and people that have mental illness. So, what about this? It's all on your head? Well, basically, pain is a conscious condition. That you need to be conscious to feel pain, to experience pain, to remember pain, to manage your pain, to work with your pain. And some people, including some doctors, come to you and to say, hey, it's all in your head. Well, probably it's correct. Basically, you feel it in your spinal cord, but you process all the information in your head. And you feel, you live, you remember with your head. I'm not a philosopher, but basically, that puts you in the context of feeling something and being something. If 90% of the time my pain is interfering with my life, of course it's in my head. Necessary it's in my head. So what? It's too complex. This is my team. Some of them are not there anymore, but some of them, it's a bit bigger now. That pain is so complex that they have no answer as a doctor, or the physiotherapist has no answer, or the surgeon has no answer. We need to understand that for this complexity of things, we need a team. And the team, when they are interdisciplinary, are demonstrated that are better than the single specialist. Very simple, rocket science. The good news is that it costs less to everyone. The patients, the institutions, and the society. Look, how can a doctor treat insomnia? Or how can a doctor do not treat insomnia? How much of you do not have good sleep? You don't want to talk about that. It's the most common reaction. And pain, yeah, okay, one. But the point is that pain and insomnia are strictly related. If you don't treat insomnia, you will not treat pain. And insomnia is the most powerful aspect of our normal activity, or the lack of sleep, is that predicts pain and pain-related disability, even more than pain intensity. So it's not just a pill. It's something that needs to be worked on within a multi- and interdisciplinary team. A normal physical function. John said, the more active you are, the more core muscles, nice, huh? And back, and you get better. Probably yes. Which is the best physiotherapy? The one you like. Because it's the one you are going to continue to do. The main problem with physical therapy is continuity. It's, no, you know, spring is coming. I'm going to the gym. Oh, winter is coming. I'm going to swim. But I last no more than 3 weeks. This is the history of physical activity, one you don't want or you don't like, or it's not useful for you. And the point is that there are good pains. If you don't feel pain, we die. And then there are bad pains, the one that, you know, you're doing too much or you're doing too bad. So the fact that you need, I don't know, a physiotherapist, or at least a coach to help you in functioning, to tell you, this is a good pain, this is a bad pain, continue, go over. And if you do that, and these are numbers from the best clinic in the world, it's not my clinic yet, modestly. I would say, is it the red one? Yeah. So, few patients, 1/4 of the patients, if are treated in multidisciplinary or interdisciplinary teams, will not get better. Most of the patients will get better in terms of pain intensity. And in terms of disability, this is Boston, okay? Children's Boston. In terms of disability, 90% of the patient will get better. So just to let you know, if you have chronic pain, the best country in the world to live is Canada. Because we have more chronic pain services and centers than any other part of the world based on the population. So just to let you know, Montreal has 2 chronic pain clinics, one in this institution, one in my institution, for children, which is an amazing thing. Even though we are able to treat 5% of the patients that needs treatment. That's why it's a question of resources. So the fact is, who is going to take care of you? And the answer is yourself. If you do not take care of yourself, you have almost 10 times more chances of not succeeding, even if you go to the Children's Hospital in Boston. The moment you, me, as a patient, we take care of ourselves in a proactive manner, being part of a treatment program within your specialist, this is the moment you get better. And what about the medication? You are my doctor, so I have to sell something. Meds are good. So this is Cochrane. Everything is coming from 2017, and the message is for all our meds, we don't have a clue. So my psychologist should be the chief of the team, right? Because, so at some point we hired this person. This is our nurse. It's an amazing person, and especially because she's a mother. And mothers are super simple. Go to the point. Hey, doc, what are you doing with your meds? And I say, I had no idea. So I went to read. I put a fellow reading that. We found 0 papers talking about risk-benefit ratio in meds in children. 0. So let's go and study it. Oops. I give a med, and I have 8 chances to 10 of my kids that will have adverse effects. And the more meds I give, the more adverse effect they will have. And the point is at 3, if I have to give 3 meds, this is something that you will have adverse effect no matter what. And what happened about the efficacy? Okay, you are good, but quite. But the more meds I need to give you, the less chances you have to be okay. So the idea of multimodal analgesia for chronic pain seems not to work. We are hesitating to publish this data because we know they will kill us the moment this comes in any paper. So look at this. There are scientists here. I was honored to meet some of them here today. We go from basic research to translational research, which is so we take the information from animals, you try to understand how it works in human, and then we do clinical research. And this means that you need to analyze a few numbers of people, okay? But in clinical care, it's different. In clinical care, we have the evidence, right? So we go read the papers, then it's you and me, and at the end, it's you. N equals 1. That needs to get the benefit of what we research. But what happens when you don't have evidence? Oops, it's you and me, and you. So this is something, when I came to Montreal, I met a guy, this one, and he started to talk to me about personalized medicine, right? You have to change the photo, okay? Very more realistic. And then he introduced me this person who is a scientist who was working on it, still working with us in personalized medicine, trying to answer this question: what is wrong with me? And so what we did is, they create, I support, a program to understand the sensation of the patient. Very complex, but in terms of how you understand this is, how is your nociceptive system is working. If it's sensoring pain in a different way, QST, or your descending inhibitory system, which is your own morphine or cannabinoids, is working or not. And what we found is that in my clinic, 96% of the patients do not have the nociceptive system working well. But just that. So, can we come out with a personalized treatment for these people? So, basically, you are not the same like me. If you have a descending inhibitory system that is not working, but you do not have a peripheral sensitization or central sensitization, which are just names, I may not doing a good job, as I showed you before, applying the normal and traditional protocols, guidelines, and suggestion of experts, especially if I had to put 1, 2, 3, 6, 10 meds to treat you. So we decide to organize a mechanism-based treatment protocol, very simple, and say if you have a peripheral sensitization, so you are feeling more in your peripheral nervous system up to the first neuron, we are going to treat it with a specific type of meds. And if you have a central sensitization, we are going to treat it with others. And if you have a descending inhibitory system that is not working, we are going to treat you, for example, with physical therapy and not with meds. The first analysis of this simple protocol shows that the efficacy is as or a bit more than with the normal traditional programs, but with much less adverse effects. Definitely is cheaper. So the cost of the analysis, measuring you before you come into the clinic, pays, with all the savings that we have, the cost of all this structure. So, how many of you have allergies? Lot, huh? Well, if you live in Montreal and you have no allergies, you are an alien. So some of you are lying, okay? But the fact is that we need to look at people and not analyze people. We need to listen to people. And one of the things that people are telling us when we are in the clinic is that, first, there are many names, and that names has similar symptoms. For example, there's a combination of symptoms. When you have fibromyalgia, you will have IBD very often, 80% of the cases. So just put that examples, simple examples, right? You combine this with TMD, which is temporomandibular joint disease, and then you say, okay, 70% of these guys have fibromyalgia, so who is who? I put you a name. And then someone would say, you have chronic widespread pain. When you have all this, and this is a condition, chronic widespread pain. What are you telling, doctor? I'm telling that everything is hurting. Yes, wow, fantastic. And you study 10 years, do 2 fellowships, go to 2 universities to tell me that I'm having pain all over my plate. Fantastic. Can I have your salary? One of those guys asked me. So the main issue is try to understand. And you people are telling us that when I have allergies, I may have also other conditions, or the contrary, whatever you want. If I have migraines, I may have more allergies. If I have fibromyalgia, I might have more allergies. Someone told me that people with Marfan have 9 times more allergies than normal population, or people without Marfan, normal population. So the question is, does the mast cells play a role? Who ever heard about the mast cells before? 2. The one was today, right? So the main issue is, the mast cells are cells that are necessary to live. If you don't have mast cells, you die. More likely, you may hear about mast cells. When the mast cells they are active, you can have cutaneous reactions, allergic reactions, or you may have respiratory problems, asthma, or you can have other things. For example, hypotension or syncope, or you may have fatigue and muscular weakness, or you may have abdominal cramps and diarrhea, or you may have aches and bone pains with the normal bone, or you can be anxious or depressed. I assume that everyone here may have these symptoms at some point in life. Why these pains are associated with the mast cells? Because the mast cells are close to the nerves, and when they get active, they attack the nerve. And this can happen in the central nervous system that explains headaches, and it can attack the peripheral nerves that explain the bone aches and the neuropathic pains and the muscular pains. So this person here is Ruda. She's a chair of excellence in Canada. It works at McGill, but I'm sure I know that there's a couple of doctors at the University of Montreal working also in this program. And she, I started to work with her a few years ago on this topic, and she said that the immune function is very likely to contribute to the pathophysiology of pain. So we complete a study, I helped her to complete a study that showed two things, basically two things. There are some natural killers of T cells that are specific, that are able to repair your nerves that are not present when you have fibromyalgia. So you have less mechanics, people that get you better. And when you have fibromyalgia compared with people who don't have fibromyalgia, you will have more beta cells. And beta cells are those who are responsible for allergies. And they are the ones who activate the mast cells. So if you see this small square here, these guys, very strong, with 16 more times trypsin inside, these are the mast cells, close to the nerves and close to the vessels. No. So we studied that with the translational reserve. Translational reserve. This guy didn't understand that I come from Argentina and Italy. It's very difficult for you, this. So, and we found that if we treat patients, rats, with mast cells, they get better. Okay, we can prevent this with anti-asthmatic, the thing that you put in your eyes. And then we treat patients. And most of those patients get better. Just with an anti-asthmatic. So we are doing a study. We are finishing in a few days with a study. Okay, who has migraine? A lot of people here. These are the guidelines that just were edited last month, the 16th of August. And it said, you know what? Placebo and meds are almost the same. Bad news. Good news. Humanized antibodies for this receptor specific in the market, probably ready to be used in Canada. No paid by the government yet. Probably we are going to start this in the next winter in kids. Super effective, especially when you are not having benefit with the meds. Super expensive. So, now is 1 minute. This is the message. We are all in the same boat. We can't continue to complain. But if we don't do something, nothing will change, and we are part of the problem. Look, this is a meta-analysis. Meta-analysis is we put all the information about something, and we analyze what is inside. And they found, in this nice meta-analysis, only 18 studies talking about pain and Marfan syndrome. In an adults, it could be a bit more. Only 2 studies I found talking about pain in Marfan syndrome, exclusively in Marfan syndrome. LDS, I think it's 0. So the message is, if you want that things changed, you need to make us to talk about what you feel. If you don't do that, we are not going to change. If we don't study you, if we don't understand you, if we don't look for something specific for you, nothing will change. Do not ask the doctors to do that job. What you have to do is to make us understand you. And this is the best way to treat your pain. Thank you.
Est-ce qu'on a des questions pour Dr. Ingelmo? Il y en a une ici, Sam? Christian?
Doctor, while we're helping you to help us in the transitional period when you come up with all these solutions, getting back to meds, what are your thoughts on medical marijuana as a treatment, maybe temporary or permanent, in terms of the chronic pain and all types of pain that patients have today?
La question, c'est quoi votre opinion vis-à-vis le cannabis médical, vis-à-vis la douleur de base ou n'importe quel type de douleur?
Two good news. The first one is that we have receptor for marijuana, so it's there for something. Normally, it's for keep our things in a specific level of regulation. I think it works. It can work. There are some information coming every day. You will read a new paper on that. I can give you an expert opinion because I treat children most of the time. I use medical marijuana, CBD, and THC also to treat children with pain, and in some cases it works very well. My advice is always the same. I was part of the process that produced the opioid emergency. I was in my 40s or 30s when we put a lot of emphasis on treat pain and giving opioids to a lot of people, and we see the consequences now. I don't want to see that with medical marijuana. I expect that the science now will answer questions faster. The information coming from the consortium in Germany 6 weeks ago showed that for MSK pain may have some benefit. We don't have a clue, even if marijuana was being used for centuries to treat headache, if medical marijuana is useful for headache. We know that in terms of neuropathic pain, the benefits are not so impressive. We are quite certain that the effects of medical marijuana, especially to CBD, are super good when you have spasms or dystonia. Super good. We use it in Tourette's, we use it in MS, and we use it in kids with spasticity. Especially CBD. The problem is that we don't know the dose. We don't know the concentration. We don't know the association between THC and CBD. So it's a trial error proof. I would say here in Canada we have probably the best centers for, especially in Montreal, for or the best specialists in the world to indicate how to use, how to research in medical marijuana. So we are in a good position. Up to date, I would say we're still searching trying to answer questions rather than to give you the answers.
Merci. Est-ce que vous voulez que je répète en français ou ça va comme ça? OK. Essentiellement, ils disent que c'est inclusif. On ne sait pas encore c'est quoi l'état, l'impact de cannabis médical sur les patients, mais dans certains types de cas, il s'en sert beaucoup pour les jeunes. On sait que c'est très efficace quand il y a quelque chose relié à neurologique, spécialement des epileptic seizures.
De l'épilepsie.
OK, merci. On sait que ça fonctionne très bien. Mais on apprend encore, puis c'est pas tout à fait définitif parce que c'est tellement nouveau en termes de recherche. Christian?
Et qu'on ne connaît pas très bien la dose. Donc on ne sait pas très bien à quelle quantité on peut donner, puis où est la ligne entre la sécurité puis le bénéfice de traitement.
Merci. Christian?
More of a comment, small question. Excellent presentation. I really enjoyed this presentation with many. Will the slides be available on the website or to us?
Yes. So, la question, est-ce qu'il a bien aimé la présentation? Est-ce que les diapos vont être disponibles par après? La réponse, c'est que pas juste les diapos, mais les vidéos de hier ainsi qu'aujourd'hui vont être disponibles sur le site web de HAD ainsi que GADA et Loeys-Dietz Foundation. Ça va nous prendre quelques semaines pour faire toute la editing, etc. Mais vous allez avoir accès facilement à hier et aujourd'hui, diapos et vidéos. Okay. Est-ce qu'il y a d'autres questions pour Dr. Ingelmo? C'est bon? OK. Merci beaucoup.